Professor Raymaker is presenting PAS 512, Clinical Medicine I HEENT Module, Ears 1, Part 1. By the end of this lecture, learners are expected to recognize common auricular congenital anatomical disorders of the ear, discuss associated disorders and indications for further testing, demonstrate knowledge of treatment, and anticipate complications of failure to treat. In regards to acquired auricular disorder, traumatic auricular hematoma, discuss clinical presentation, history and underlying physiology, formulate treatment plan, and anticipate complications of failure to treat. Review of the outer ear anatomy. The outer ear includes the auricle, cartilage covered by skin placed on opposite sides of the head, auditory canal, also called the ear canal or external auditory canal, abbreviated as EAC, and the eardrum outer layer, also called the tympanic membrane. In the image below, you'll note the outer ear, the middle ear, and the inner ear. The outer ear and the middle ear separated by the eardrum. In this lecture, I will discuss the auricular congenital anatomic disorders of the ear, including Darwin's tubercle, preauricular pits and tags, and I will briefly mention bat, lop, Stahl's bar, cryptotia, and rim kink. Darwin's tubercle is a small projection from the upper end of the free margin of the helix of the ear. It's vestigial and an atavistic feature. Side note about physical vestiges, such as the appendix. A vestigial characteristic occurs consistently in most individuals in a species, while an atavism is a rare resurgence of a characteristic that has been absent in previous generations. Darwin's tubercle is present in only 10% of the population, may or may not seen in multiple family members. There are no associated congenital disorders. Common characteristics of preauricular pits and tags include unilateral or bilateral, multiple or solitary presence. In the image you'll see on the right, there's both a pit and a tag. These may be located together, however you may have just one or the other. They are relatively common anomalies, prevalence of 5 to 10 per 1,000 births. Generally regarded as minor abnormalities with only cosmetic consequences, should always rule out syndromes in a child with preauricular pits and tags because of possible connection between preauricular skin lesions and hearing loss. However, there are lack of adequate studies. There's also evidence on the relationship between isolated preauricular lesions and renal abnormalities, but results of these studies are conflicting. In regards to hearing loss, hearing test is a standard for all children born in the United States. Therefore, further testing should be based on results of those hearing tests. In regards to renal ultrasound, in response to possibility of a relationship between isolated preauricular lesions, renal ultrasound is not indicated in isolated preauricular lesions. Preauricular pits are characterized by congenital superficial dimples or pits found anterior to the tragus. Other names include preauricular sinus, congenital auricular fistula, and preauricular fistula. A preauricular pit occurs as a result of faulty fusion in the development of the ear. It is not closed by itself, therefore surgical excision is the management of choice. Complications of preauricular pits can include infection, which may also include cellulitis and abscess, erythema, edema, draining purulent material, granulation around the pit, tenderness, and previous surgical scar with underlying swelling. An infected preauricular sinus should be treated with antibiotics before surgical removal. Preauricular tags are congenital protuberant fleshy papules or tags found anterior to the tragus. These can also be surgically excised, and like the preauricular pits, which are incised, these surgery should be performed by a surgeon or ENT specialist due to the proximity of the facial nerve. With the exception of Darwin's tubercle, which is not a true deformity, any external ear abnormality may be associated with hearing and renal abnormalities. Therefore, presence of these abnormalities should prompt consideration of further testing. Next, I'll be discussing acquired outer ear disorders of the auricle called the auricular hematoma. The other topics in this slide will be discussed in future lectures. Traumatic auricular hematoma is a hematoma between the cartilage and perichondrium from blunt otologic trauma, such as a slap or punch. Signs and symptoms include otalgia, which is ear pain, auricular deformity, including edema, hematoma, which is bluish, fluctuant doughing swelling of the auricle, and loss of contour of the pinna. Physical exams should assess the head, cranial nerves, vasculature, temporal bone, pinna, external auditory canal, tympanic membrane, hearing, and any other concomitant injuries. Complications include necrosis, which you'll see there on the right, due to ischemia, perichondritis, which is an inflammation of the perichondrium, and something commonly known as cauliflower ear, which you can see in picture 3 to the right. Treatment of traumatic auricular hematoma must include drainage plus pressure immediately. Those are key essential interventions to prevent cosmetic deformity. And the reason for this is ear cartilage does not have any direct blood supply. It's nutritionally dependent upon the perichondrium, as depicted on the image to the right of this text. Hematoma is greater than 7 days old. You want to refer to plastic surgery or otolaryngologist due to scar tissue formation. In the image below, you can see the formation of a hematoma and scar. You can see the hematoma on the left starting to grow. In the middle, you have blood and serous fluid. On the right, the fluid solidifies, calcifies, and that lack of blood flow by compression of the perichondrium is going to cause necrotic tissue. Drainage can include both needle aspiration and incision. Needle aspiration, the advantage is it's quick and easy with minimal pain. The disadvantage is there's a high risk of hematoma returning. Therefore, many professionals no longer recommend needle aspiration for treatment. However, it is still often performed. Should you need to perform this, you would use an 18 or 20 gauge needle, which the higher the needle gauge, the smaller the needle. Incision and drainage, I&D, incision extending the entire length of the hematoma allows the hematoma to drain out the incision. The advantage of this is it's quick and easy, and it has a lower chance of hematoma reoccurrence. The negative to it is that it is more painful, and there is still a slight chance that the hematoma may come back. Regardless of whether you use an incision or you choose to use drainage via needle aspiration, you need to apply pressure following these interventions. And you apply digital pressure for 5 to 10 minutes and then apply compression dressing. So a simple dressing is not adequate. You have to have a compression dressing in order for adequate ear healing. Follow-up includes reevaluation every 24 hours for 3 to 5 days for evaluation of possible reaccumulation of signs of infection. The patients to avoid aspirin and other NSAIDs, non-steroidal anti-inflammatory drugs. For patients on anticoagulants, you want to consult with a hematologist. It also includes 7 to 10 day course of empiric antibiotics. Empiric meaning that you are not testing for it. These are covering the most commonly found pathogens, with activity against skin flora and Pseudomonas aeruginosa. In adults, this includes levofloxacin. In patients less than 18 years old, levofloxacin is contraindicated. Therefore, amoxicillin and clavulanic acid or augmentin is indicated. As far as returning to sports, patients are to refrain from activity that replaces the ear at risk for additional trauma until the ear is healed. Frequently, this can be 7 to 10 days after the injury if the hematoma is not reaccumulated. And athletes are strongly advised to wear protective headgear to protect injury. This concludes the first lecture on ears. Students are now asked to go to the YouTube video of ear hematoma emergency. The link can be found on Blackboard. Thank you.